Genital human papillomavirus, or HPV, is the most common sexually transmitted infection in the world. In the U.S., an estimated 42 million people are infected with a disease-causing genital HPV type, and approximately 13 million are newly infected every year. Worldwide, an estimated 690,000 cancers, most commonly cervical and oropharyngeal, are attributable to HPV each year. The majority of cervical cancer cases and related deaths occur in low and middle-income countries, where cervical cancer screening is not widely available. Fortunately, there are highly effective vaccines that can prevent HPV infection and decrease the burden of disease due to HPV. HPV infection is caused by human papillomaviruses, which are DNA viruses from the Papillomavirus family. HPV is usually transmitted through sexual contact, and most infections go unnoticed. More than 90% of new infections become non-detectable on their own within 1 to 2 years. More than 200 different HPV types have been identified. At least 12 of these have been shown to be oncogenic, or high risk. High risk means that the HPV subtype has been associated with a cancer, though it does not necessarily mean a particular patient is high risk for cancer. Worldwide, HPV 16 and HPV 18 are responsible for about 70% of cervical cancers, and for an even higher percentage of other HPV attributable cancers. While the most common types of HPV attributable cancers are of the cervix and oropharynx, HPV, in particular HPV 16, can also cause cancers of the anus, vagina, vulva, and penis. Though most cases of HPV are asymptomatic, when symptoms do appear, they can take many forms, including anogenital warts and recurrent respiratory papillomatosis. HPV 6 and HPV 11 are usually the causes of such presentations. Of note, HPV 6 and 11 are not oncogenic. The warts they cause are not precancers and are outside the scope of this discussion. Most genital HPV infections are diagnosed in the setting of screening for cervical cancer. There is no treatment for HPV itself. Most infections become non-detectable over time, and when that occurs, the patient is no longer considered to be at increased risk for cervical cancer. However, these infections can reactivate, and thus close surveillance is needed. When HPV testing is positive, further evaluation is required, including HPV subtyping, cytology, and possible colposcopy and biopsy. If precancerous lesions are identified, treatment can prevent progression to cervical cancer. Currently, cervical cancer is the only HPV-associated cancer with an approved approach to screening, which is done by HPV testing or cervical cytology or both. So how does this progression from virus to cancer occur? First, the virus infects the basal epithelial cells, often at the endocervical-ectocervical junction. Disruption in the epithelium allows the virus access to the cell, and thus to the cell nucleus. Infections that integrate into the cell nuclei can interfere with cell replication, division, and signaling, causing infected cells to multiply uncontrollably and progress to precancers or potentially to invasive cancer. Patients who are immunocompromised, patients who smoke, and those who have more aggressive HPV types are at higher risk of progression. Development of high-grade dysplasia such as cervical intraepithelial neoplasia, or CIN grade 2 or 3, can happen rapidly, but most cases of cancer take years to develop. Since HPV vaccination can actually prevent HPV infection, if given before exposure to the virus, it can prevent precancers and cancers from occurring at all. HPV vaccines are based on virus-like particles, or VLPs, which are small particles made up of proteins that mimic the external structure of the HPV virus. VLPs do not contain genetic material from the virus and therefore cannot cause infection. The first vaccines were licensed in 2006 and 2009 and targeted 4 or 2 types of HPV, respectively. In 2014, a vaccine was licensed that targeted 9 different HPV types, 2 that cause genital warts and 7 that cause cancer. These 7 oncogenic strains account for approximately 90% of HPV attributable cancers worldwide. Currently, only the 9-valent vaccine is distributed in the United States. International randomized controlled trials involving female participants aged 15 to 26 have shown vaccine efficacy of at least 96% for the prevention of cervical precancers, owing to vaccine-targeted HPV types in per-protocol populations. These studies were conducted in women who had no evidence of infection with or exposure to a given HPV type at the time of vaccination, and who had received all 3 vaccine doses. Trials of the quadrivalent vaccine also demonstrated 100% efficacy for the prevention of external anogenital, vaginal, and cervical lesions when given to patients prior to exposure to HPV infection. Subsequent studies in children ages 9 to 15 demonstrated levels of antibodies following HPV vaccination that were non-inferior to or even higher than those in the women in the trials that showed vaccine efficacy. Similar vaccine efficacy has been demonstrated in men. Follow-up of women in Nordic countries for as long as 12 years after vaccination showed no cases of HPV-16 or HPV-18 attributable cervical precancers over that time. Studies have also found that vaccination produces higher antibody titers than natural infection. Because HPV vaccination does not affect clinical course or outcomes once infection is established, the vaccine must be administered before patients encounter the HPV vaccine-associated subtypes. HPV infection is transmitted by skin-to-skin genital contact, so the vaccine should ideally be given before the onset of any sexual activity. There is extensive evidence regarding the safety of these vaccines, including data from more than 15 years of post-licensure monitoring. Through 2021, more than 135 million doses of the HPV vaccine had been distributed in the U.S., and safety monitoring in the U.S. and other countries has not detected any safety concerns other than rare allergic reactions. Large population-based studies have also shown no safety concerns generally or with respect to death, autoimmune conditions, or neurologic conditions. "12 years after the U.S. HPV vaccination program launched, the prevalence of HPV genital infections caused by HPV types that are covered by the vaccine had decreased by 88% among adolescents aged 14 to 19 and 81% among persons 20 to 24 years old. The prevalence of HPV has dropped even among non-vaccinated patients, which suggests a herd immunity effect. While randomized trials have not been sufficiently long in duration to assess the impact on cervical cancer risk, epidemiological data have shown reduced rates of cervical cancer in association with HPV vaccination in several countries. Since cervical cancer incidence has decreased in the past several decades due to vaccination, screening, and management of precancers, oropharyngeal cancer is now the most common HPV attributable cancer in the U.S., with most cases caused by HPV-16 and most occurring in men. In the U.S., vaccination for HPV can be initiated at age 9, with a recommendation to vaccinate by at least ages 11 to 12. It is recommended that all children receive the full vaccination series. There's another benefit to vaccinating when a patient is young. Patients who receive the vaccine before age 15 require only 2 doses, while those 15 or older need 3 doses to complete a full course. Patients who are immunocompromised should also receive 3 doses. Vaccination is recommended for everyone up to age 26. For persons between the ages of 27 and 45, shared decision-making can occur between patients and providers. In 2023, 76.8% of adolescents aged 13 to 17 in the U.S. had received at least one HPV vaccine dose, and only 61.4% were up to date with their HPV vaccine course. For other vaccines recommended for adolescents, coverage is close to 90%, so HPV vaccination is lagging behind. Providers can help increase the HPV vaccination numbers by speaking openly and honestly with patients about this vaccine. Many parents and teens may have questions or concerns about HPV vaccination. It is helpful to begin with open-ended questions and allow families to share their concerns before jumping in with data or recommendations. The Centers for Disease Control and Prevention and the American Academy of Pediatrics recommend discussing the HPV vaccine with all other approved vaccinations at the same visit. For example, you can explain that at a child's upcoming visit, they'll receive vaccines to protect them against meningitis, HPV-related cancers, and whooping cough. As with other vaccines, sending reminders by mail, text, or phone can be effective in making sure patients initiate and complete the vaccination series. If parents worry that their child is too young to need this vaccine, clinicians can explain that this vaccine has been shown to be safe in children as young as 9 years of age, and that it only works if given to children before they encounter specific types of HPV. In other words, before an individual becomes sexually active. Of note, numerous studies have shown no increase in early sexual activity or no change in age at starting sexual activity in those who have had the vaccine as compared to those who have not. Parents can think about this vaccine like they think about wearing a seatbelt. You put it on before you start driving so that if you encounter danger, you're already protected. Clinicians should emphasize that cancer prevention is the main goal of the HPV vaccine. It can be useful to review the strong evidence to support that the vaccine is both safe and effective, and share that they would recommend this vaccine to their own children and family members. Emphasize that all children should receive this vaccine. If a family declines HPV vaccination, leave the door open to future conversations by acknowledging their concerns, explaining that if they change their mind, they can return anytime, and mentioning that you will revisit the discussion in the future. It can be helpful to emphasize that you share their same goals, which are to keep their child healthy and safe. Regardless of vaccination history, cervical cancer screening should be continued at regular intervals. For more information about this vaccine, please visit the CDC website and cancer.gov. Funding for this video is provided by the Doris Duke Foundation, committed to building a creative, equitable, and sustainable future.